Well, good evening or good day. It's Charlie. This is the podcast To Hell and Back. It is January 30th. It's Massachusetts, where I am. Where my guest is, it's Connecticut. And we're both on the same time zone, so it's 6 o'clock in the Eastern time. And today, the plan is to continue into the third part of a conversation with Seth Axelrod, who, if you have had a chance to listen to either or both of the last two podcasts, we've been talking for 2 hours total about the experiences he's had living with cancer for the last 6 years, what the challenges have been, how he has coped with that, and with particular reference to some DBT skills. And so we're going to continue today. And, and it might seem like, oh my God, that's a lot of time. But I have to tell you, my experience is that it's been like just a drop of time, because trying to get the story, trying to hear what has happened, what has unfolded, having space and time to react to that, and reflect on that, and have my own emotional responses to that, and find out more about that, and learn how he's coped with that, and then follow up on that. It's just unbelievable how big this is. And I think all of you who are listening, whatever have been the biggest challenges in your life, I mean, it's the same thing. It's like time gets compressed. There's so much to put in. So we've been doing this, and today we're going to continue, and I think get into some more details. And I think the stage is set really to jump into some things we haven't been able to get to yet. And so I have a little outline of how we're going to do this to try to, that Seth and I have worked on together. And I also want to announce that I'm really very touched and pleased that his wife, Rebecca, who has, of course, gone through all of this with him for the last 6 years, and life before that, and raising children with him, and sharing a house with him, and everything, that Rebecca has agreed to come on the podcast next week, which will be February 6th, for an hour. And we'll continue the conversation with Seth here, but then turn over to Rebecca and what her experiences have been, her reflections, her perspective, what she's had to cope with, how she's done that, just wherever. We'll see where it goes. But I think it's a real opportunity that I'm grateful for, and I hope that you'll tune in and be grateful for. So here's, I just want to set the stage for what we're doing, partly just to help us be on track and cover the things we want to cover, because I've realized this can be such a deep and meandering conversation. So here's what I've come to in conjunction with Seth and talking about it. Here's the game plan. As somebody who wanted to spend his life playing professional basketball, that always comes to mind. Here's the game plan. First, I'm going to start out with just a very brief recap of what we've covered. Not that you haven't listened, but just to put it together to kind of like have a starting point to take off from. And then I'm going to hand it over to Seth to tell more details and of the evolution of how this has happened since he was first diagnosed, which we've spent time on, and he faced surgery, which we've started to spend time on. But he's going to tell more about the actual illness and the unfolding of the illness, the unfolding of all of the pluses and minuses of how people coped with it and how people assessed it, and what the choices were for treatment, and how he made those decisions, and how he kept his life going during this time, and all the way right up to now. And so that's a big job. And so we'll get right to him in just a couple minutes, but we'll do that. And during that, I'm hoping we'll move in and out of how he has coped with that from an emotional point of view, and as a person who's having to deal with all of this. So that's the game plan. And it could get into lots of things. He and I have thought that huge things for him have been forms of reality acceptance, of awareness, and of being willing to accept some conditions that he might not have ever thought about before 6 years ago, having to accept and figure out what to do with. So and he's going to speak also to a question that came up on email that we haven't gotten to yet. So game plan. Okay, I have notes to keep me on track, because any of you who know me well know that going off track is my main mode. So I'd say this, up to 2013, Seth's life was moving along. He had an 11-year-old child. He had a 13-year-old child. He had a wife. They were very, a close family, as far as I can tell. He was involved in musical theater, in music. He had become a DBT teacher, an educator, an associate professor in the school in psychiatry at Yale, director of a DBT program. All of this was going on, and other things, of course, in his life. And he had a community that he was involved with in New Haven and the surrounding areas. And then he starts having pain at some point that heads into 2013. And the pain goes, as most pain does, you don't know what the source of it is. So it took a while to get to what the source of it was, but there were other ideas of what it was first, which were more benign. Figuring out what to do. Oh, it's this with it. It was in his back. It was up against a rib. And maybe there was a problem with a rib and things like that. Until later in 2013, he had an MRI because other things weren't making sense and the problem was continuing. And they discovered a tumor that was lodged against his spine and behind a rib. So it had not been easy to identify without a scan like that. And once identified, then it was also, I guess, biopsied right after that, Seth. I realized I wasn't sure about that.
Yes. Yeah. That's correct.
He had a biopsy, and it was a bone tumor that was known as a chondrosarcoma, which is actually a tumor of cartilage, which is not that common, and which comes in different varieties, and he'll tell you about that, some of which have better prognoses than others. So that was still being worked up. And of course, he had to come to grips with, oh my God, I have cancer, which is kind of like not easy to wrap your mind around. And he worked, so on one track, he was beginning the path of acceptance of, oh my God, this is what I have, without yet knowing what it would mean. So he's on a track of uncertainty, which has continued up to this very day, of what's going to happen, what's going to happen, what's going to happen. Anxiety, sometimes fear, pain, some surprising twists and turns in the course, some decisions to make. And so he was making decisions in 2013, 2014 about what to do. And there were options in front of him, and there were back and forth between this versus this. So he was really having to tap into like really researching, learning from experts, talking to people that are at Yale, talking to people by Massachusetts, Pennsylvania, figuring out what to do. Just his life was sort of began to be taken over to some degree by this while he continued to do his work. And then he headed into a surgery. And that's about as far as we were getting in our conversation, is that he was going to go into a surgery. I'll let him tell you about that as part of the story. And those are, I think, I wanted to comment on some things that are really, I think, outstanding things that stay with me, things I've learned from Seth already that are probably going to affect how I cope with future adversity, to tell you the truth. Afraid I'm going to cry. I bet there's been moments like that for you, Seth.
Oh boy. I'm very touched, Charlie. I'm really, truly,
Yeah.
And I want to hear what you want to say, but I'm touched.
Thank you.
Very much.
His level of openness is extraordinary. His transparency, his willingness to come here, his genuineness with not only this podcast, but obviously this reflects his genuineness across the board with his colleagues, his friends, his family. I've been impressed how he has, definitely better than I could, cultivate his social support and keep it on board with him during this time. I think he's been really attentive to who is around him. It's almost like beginning in 2013, 2014, a journey began of an entire village, and the village is friends of Seth, and Seth's community. And he keeps them informed. He reinforces them for staying in touch. He's grateful genuinely that they're involved. So all of that kept going. So I've been impressed with that. It really stands out to me. It's not a DBT skill per se, But I think social support and maintaining a community of connection while you go through something like this is probably as important as almost anything. There's also been his closeness with his wife and his family. This wasn't one of those situations, of which there are many, where people, in order to cope with severe distress, pull away from the people they're close to and don't talk to them as much. Actually, it's far, what I can tell, I'm very interested in talking to Rebecca, you know, from the beginning, there's been an ongoing, like, we're in this together, and let me keep you informed, and let me accept what help I can get. There's been this emphasis on radical acceptance of the manifestations, and such a thoughtful approach to, gee, well, I have to accept pain because I can't make it go away. I have to accept the fact that I have cancer, with whatever that means, and it could mean different things on different days. I have to accept the manifestations of having cancer, the tributaries, once you have cancer, of all of the things that it brings you in contact with, which you never dreamed of before, in your body, in your relationships, in your treatments, etc. And I've been so impressed, and I think this is a really important coping strategy. Again, that's not specifically, it's more of a social coping strategy, how to maintain your normal life to the degree you can while having your cancer life. It's sort of like, okay, now you have to add cancer life to normal life. And it's easy to imagine that cancer life is going to take over like a cancer and take over normal life. And then all you have is cancer life. But Seth has maintained within boundaries and with ongoing negotiation, how to stay involved in his work, how to stay involved in his teaching, his consulting, his involvement with colleagues, his singing, you know, his family life. So all of that I think has been very important. And we spent some time on, I won't go back over it now. I've just been so impressed, both just it's a nice quality, but also I think unbelievably helpful at times like this, the way in which he's used humor and sort of metaphor and narrative with, as we said, talked about last time, Captain or Proton, and then there's the Iron Man, and then there's other things that sort of like to put your illness journey into a story that might have some humor in it, might have some lightness in it, as well as heaviness, and might have a good outcome. You know, all of that might have some hope in it. So that's my introduction. I tried to be quicker than I usually am. I've left some time, I think, most of the time for Seth to just pick up wherever you want, Seth. But I mean, I think where your story in 2013, 2014, and just help people see what you've been through.
Thank you, Charlie. I want to say that something we talked about last time we spoke offline was what a privilege this is. You know, what a privilege this is to be speaking with you, to be getting your responses to this, and all the various ways that I have an experience of privilege in terms of the resources I've been able to throw at what I'm going through, and access to things, and privilege around going through this with community, which we spoke about in the first time, our first session, that this is something that when I felt need, and when I was concerned about my family, and I did broadcast within a closed Facebook, but I did broadcast that people were responsive, and it made a huge difference, and still does. You know, that when I put a post on this saga, that it gets, you know, 80 to 100 plus, whatever it is,
Wow.
people responding with likes or comments or this or that, and when I see people, even if I don't see them often, you know, and they tell me about following this story, and they talk about it with people in their lives, and I have this experience, you know, that I get that from sharing, really does help a lot. Now, this is a new experience, going public in this kind of, you know, without any controlled filter, whoever, and I don't, you know, I expect that lots of people who know me in different ways are going to hear this, listen to this, and I don't exactly know what that will do. Right. And yet, when I think about it, I see all kinds of positives. You know, I get to have this experience that I could be going through this you know, devastating thing, and have people's genuine responses to it, as opposed to, well, again, going back to the first session, being invisible. Like, I'm doing this, and it's, and what you said, some people just deal with it themselves. You know, they don't share it. There was a psychiatrist, very highly regarded, who passed away some years ago. We have a few, but one of them, going back several years, worked up until he died of cancer. I don't know what cancer that was. I never knew he had cancer. Very few people in the work environment did. And I respect that he also chose to, you know, work. But that was a very different approach than I've had, you know, and that's, you know, that's me, that's my choice. Anyway, but I wanted to say that it's humbling and kind of amazing to be part of something like this, and just want to put that out there. I have been tempted to touch on the humor thing, and Rebecca and I talking about this podcast and reflecting and just noticing what a huge piece of the coping that's been. That there has been opportunities for laughter regularly. You know, there's different things, and I'll share one. Today, I worked today. I was at work today. I had medical appointments today, and met with a resident as part of my medical appointments, and he said something which I hear a lot, and this connects to one of our favorite family jokes. Is if you want to look really good, get cancer, you know, because when you have cancer, because I'll tell you, when I talk to people and they know I have cancer, and this guy today, he told, you know, after interviewing me and doing the thing, he said, you know, you look great.
Oh, right.
And I gotta tell you, I hear so often about how good looking I am. I had cancer. I don't know if I was good looking then. I have no idea. But now I'll tell you, I am like a really good looking guy.
You've gotten better and better looking.
I am.
Yeah.
And my kids, you know, they ask me, how many people told you you look good? You know, I come back to somewhere. I'm like, oh, this person, that. Anyway, that's
that is funny.
Yeah, there's another favorite one I may toss out later if I have the chance. But what I'd like to do, thinking about our talks, I haven't really laid things out, and I wanted to give a few facts about the disease, and then also run through some of the bare bones of the story, just to help put things in context for people who listen to these. One is the chondrosarcoma and the cancer, and it's unusual compared to some other cancers in that it can be aggressive and slow growing at the same time. If it's high grade, and in my story, mine originally was thought to be low grade, but it's high grade. If it's high grade, it's aggressive. Aggressive means that it likes to spread. That once you have it in one place, it likes to travel to other places and take root and do that. And that makes it hard to treat. But it's slow growing. When it hits somewhere, the original one, and where it hits, it usually grows fairly slowly. And unlike some cancers where you get a cancer and there's kind of this urgency, oh, we have to remove it immediately because it's growing, it's going to cause more damage, There's the chondrosarcoma can start growing much faster at certain stages of the disease, but for the most part, it grows slowly enough that even taking a few months to sort out a treatment, it isn't going to change the prognosis, you know, generally speaking.
Got it.
And so, yeah, so that's really allowed me to be a little bit slow and deliberate, even though I often try to make things occur within weeks, you know, days or weeks, and I often do. I can wait. You know, right now I'm about to start a new treatment. It's not going to start for another few weeks. It'll take me some months to know whether it's worked or not. It may not work. I know I'll have more opportunities beyond this one. If this one doesn't do it, I've got other things I can do. And that gets into what you said, that even today I'm still making decisions. I'm still in this process. Chondrosarcoma, there are different variations, which I'm not going to go into all the variations. Aside from this, most commonly it's conventional low grade or it's high grade, and then there's other subtypes, etc. But for most of them, they're chemo resistant, meaning there's a very low chance that traditional chemotherapies will make a difference, maybe a 5% chance. And we all know that chemos can be very hard to go through. So they're rarely used. There are some cases, but they're rarely used. They're largely radiation resistant. They're not completely radiation resistant. If you put enough radiation on them, you can do something, but it changes the cost-benefit analysis. So if it's low grade and you can take it out surgically, you don't do radiation for it. If it's close to vital organs and you can't get big margins, you can't really get the tumor and around it, then what they do is they will radiate to try to clean it up, knowing that the surrounding tissue is likely to have lingering cancer risk. Mm-hmm. So that does relate to my situation, where we've talked about I got proton radiation, which is an advanced kind of radiation, specifically that helps you get close to structures, like in my case the spinal cord, because my surgery went right to the spinal cord. Yeah, or the dura, which is the tissue around the spinal cord.
Mm-hmm. Right.
I mentioned that the treatment, really the only treatments for chondrosarcoma are surgery, physically taking it out with these margins, or the radiation that I just mentioned. That's considered treatment in terms of trying to stop the cancer. Mm-hmm. But then beyond that, there isn't treatment. Once chondrosarcoma starts coming back, once it starts spreading, the only thing to do is management. It's taking out what you can see. But if it's already spreading in your system, the expectation is it will keep showing up. So current treatments are and when it moves, it almost always goes to the lungs. And that is my situation. It's gone from my spine, which fortunately it hasn't returned there, which is fortunate, but it's been showing up in my lungs and causing lung tumors. Still bone cancer, but in my lungs.
So that's led to one surgery after another? Has that been the...
So my situation, I'm going to walk through the kind of the order of things, but there was a first major surgery, and then I had another surgery, and then I've had 2 more lung surgeries and 1 ablation, which is another thing you can do to manage. Ablations are either a small incision, they go in and they blast tissue to kill it, or you can do radiation and make strong radiation hit from different directions and burn what's ever in the crosshairs.
Okay.
And that's a radiation ablation. So I had one of those.
Okay.
But these physical removing them is really only managing the disease, and it's aggressive. It'll keep showing up. It's not a good prognosis, and that's where this is. You know, some people have a bad cancer and they get a cancer, and that means that within, weeks, they're gone. I don't have that, which is, fortunately, I haven't had that immediate risk. However, it's a bad diagnosis. It's a bad cancer in that there really aren't treatments to get it under control. So what you do have, and what I've pursued, is clinical trials, where they're looking at different medications, different things. There's all the advances going on in cancer, which is wonderful. And the options for someone like me to try to get it out of my system, which is to take a chance on things and see, well, maybe this will work, maybe that will work. There's some things that you can try off-label, which means they've been approved for other cancers. And there may or may not be indication that it would help this cancer, or there's clinical trials which usually aren't for chondrosarcoma, but sometimes we can get in if it's a sarcoma trial, or if it's a early trial where they take all cancers, sometimes you can get into those. There's very, very little research on unusual conditions, because the money really goes to, rightfully, to who's the largest group that's going to benefit. So diseases like this are referred to as orphan diseases, where they borrow from the research typically from other conditions.
Right.
Yeah.
Right.
Which again, in terms of acceptance, it is what it is. It makes sense. My story, to kind of go through it, run through it a little bit quickly. We've talked about the original diagnosis. It was originally a treatment plan of removing it with the best margins we could. But it was in a very difficult place. It involved the spine and ribs. And so it was a 2-part surgery that happened one day off, another day, 22 hours, 10 hours on the first day, 12 on the second, removing vertebra and ribs and some lung in that one, and reconstructing with 5 rods and 20 plus screws, and really creative. And they were top surgeons. The plan was, and they did, took a section of a leg bone of fibula, removed it from my own leg, and fused it in above and to the vertebra above and below, into the spine, and made it living bone, so it could grow into the above and below vertebra. I have a 9-level fusion with metal and bone, which has grown in. It has fused.
9 level, you mean 9 vertebral?
9 vertebra
levels.
Yeah. Basically, the upper chest area is all like that. So very significant surgery. The good news of it was that the coping, and most of what we talked about in the earlier podcasts, were a phase of coping, of getting through this surgery with this hope of potentially having things under control. You know, we thought it was low grade. We thought there was a reasonably good chance of getting out of it, focus on physical recovery, and 90% chance thinking we're in the clear. However, it was high grade, we learned. And I still have, and had a 90% chance of not getting it to show up again in the spine, but about a 30% chance that even though they already took it out, that it would already be in the bloodstream and that it would metastasize. So I talked about, you kind of live with a lot of cancers, you might live kind of under this dark cloud. And so it was a 10% cloud, and then it was a 30% cloud. A lot of focus on recovery. In 2015, so about a year or so later, a year and some months later, it did metastasize. The first metastasis showed up. It wasn't clear at the time if it was, but we removed it, we analyzed it. It was a metastasis. There was still some hope that maybe it was done, that maybe it wasn't actually in the bloodstream because of where the original one was. Maybe it just moved a little bit.
Right.
And but the odds were poorer, and that was a significant time for me in coping that I want to come back to, was when it became clear that I was at pretty high risk for this progression that's been happening, and how that relates to skills, including mindfulness and including one of the questions that came in. From that point, there was another metastasis showed up. There weren't clinical trials that I was eligible for. I realized I wanted to do a systems treatment, not just a local at the spot treatment, but I didn't qualify for any clinical trials that made sense. So I had a ablation, and then more metastases showed up within a year. And then I still wasn't eligible for trials, but I found an off-label treatment. This was when immunotherapies, the first immunotherapies were just getting FDA approved. And there was an argument for doing an off-label, and I actually got approved, and from the drug company was going to provide free immunotherapy for me. I was scheduled to start taking it. I was presented at a tumor board, and a researcher who I'd spoken to before realized that he now did have a trial that I could do. and I didn't do the immunotherapy. I went into my first clinical trial. It was very interesting. I could go into the you know, what it was about. It was, but it had to do with ways that one mutation in my cancer might be similar to BRCA cancer. And there was a drug which is used for BRCA positive ovarian cancer. And I went on that trial. And then in terms of the story,
Wow.
you know, the story was I was getting ovarian cancer treatment. You know, like what? So what are you getting? Well, I'm being treated for ovarian cancer. I don't have ovarian cancer, but I'm getting treated for ovarian cancer.
Right.
So, but I was on that trial for about a year and a half, going through different parts of it. It unfortunately doesn't seem to have made a difference. I was able to get into a next trial, which was very exciting, which was a personalized cancer vaccine that would then be combined with a different with an immunotherapy, which I hadn't been on yet, where they actually made a vaccine specific to very small mutations in my cancer tissue. And I was on that for the past year. And unfortunately, and this one was very exciting in that it came with the possibility of cure, you know, the possibility that this could really wipe things out.
Because they were creating a vaccine specifically for your tissue.
They did.
For your cancer tissue.
For my cancer.
Not something.
We named it. On the Facebook, we had different names come up, and the winning name was Axelrod. So, but I had my vaccine, and then we added immunotherapy, but the cancer's progressed. So I'm off that clinical trial as of just recently, very recently. I'm off that clinical trial. I actually just signed in to another clinical trial, which is a targeted therapy, where there's a mutation they've identified from my cancer, which happens in about half of the people with chondrosarcoma, and I happen to have it. And they've been trying to make targeted therapies is one of the hot areas that's been in cancer. They've been working on targeted therapies for that, and I'm on an experimental targeted therapy for a specific mutation that occurred in my cancer. That's kind of just the outline, just so people can kind of hear the story. And a significant shift is going from early on thinking maybe we're out of the woods and there's a shadow, to okay, no, it's landed, and now it's this situation where we live in a reality, and I say we, my wife and I, where it's not a crisis and yet it is a crisis. You know, this is our lives. Like people hear, oh, Rebecca will tell someone, oh, my husband has has cancer, has an appointment, he's going to try to get into a clinical trial or what. Oh my God, like everything's on fire, and things aren't on fire, except they are on fire. And it's this really kind of crossroads of, but we're okay. You know, like we have our lives and we have this, which speaks to some of your introduction, which I thought was very on point of these dual kinds of existence.
Let me ask you just a in the moment question before, and then I'm really interested in what you have to say. You referenced back to a certain point when it sounded like you were aware that the pattern of metastases was developing, and that you were not out of the woods, and that you were going to say some things about use of skills there. But let me ask you about use of skills right now. When you talk, how, of course, you're many years into this. So you might say you've, had a whole learning history of how to have cancer, how to talk about having cancer and everything. But it's just, I just can imagine, I'm curious, and I can imagine that a lot of people would be curious. How are you able to sit here and tell the details of this story, sort of like as if it was a medical report? And at the same time, where I'm sitting here feeling like, well, I'm only like 2 synapses away from the fact that your limbic system, your emotional system, has got the implications emotionally of all these things are so are so big that how do you do that? Is that something conscious you do? Is it something learned? Is it something automatic?
It's hard to answer. You know, I can tell you that when I am in, you know, when I am dealing with more fear and anxiety, when there is a new thing that hits, you know, I can intellectualize as kind of a defense, you know, a coping, throw myself into researching. There's been lots of times I'll go down these rabbit holes of trying to understand this and trying to understand that, and I don't know that I mean, I feel like I'm very tied up in it. It doesn't feel like I don't feel distant from it.
Yeah.
And yet focusing, being able to talk about the details and focus on the details and work through, there's definitely a part of that that's me. You know, there's definitely a part of it that's you know, and I find it all fascinating. I mean, even when I was terrified of the surgery,
Mm-hmm.
and even when I was, you know, dealing with the pain of and the discomfort of going through this surgery, what they were able to do is miraculous. If I tell you kind of the details of how do you cut away bone away from the spinal cord without minimal risk of doing any damage to the thing.
It's unbelievable.
It's unbelievable. And I also had the contrast of two different surgery teams that were going to do it differently, where one was going to go cutting bone toward the cord. The other slid wires under the vertebra to cut them outward, away from the cord, to not be risking there was still risk. You could still nip the dura, but nothing like trying to cut toward the dura. They were cutting away from the dura. And it's just it's just fascinating. You know, it's incredible.
Thank God you have that capacity to.
Well, I have the capacity, but yeah, but it's just I could go on and on and on and on.
Yeah.
And you know, and that's been throughout. So
yeah,
you know, this wasn't my chosen hobby, but it's quite a hobby. You know, it's quite a learning about all this stuff. And one thing which I do get to do, by the way, is I've been very active. Some people listening, some people that are putting questions are on online support groups that I participate in. And one thing which has been very rewarding and very significant has been being able to share things from my learning, specifically to the chondrosarcoma community, who may not have the you know, my approach to things, and yet they can benefit from all this, you know, clinical sorting through, laying out options, describing what I've done, connecting them to clinical trials sometimes. So
that's good. That's satisfying.
It very much, very, very much. So I think I've gone through the story. There were a few things that we thought of to maybe hit on this. Some of them related to questions that came up. Yeah. One that came up from a few people from the cancer group, and could be relevant to other people using DBT for cancer, is this question about what's being accepted or what's being problem solved, and these shifts in the story from things like before the diagnosis, it was a problem of pain affecting functioning, driving, and things, and walking and things like that, and this incredible, you know, I mean, it felt like I was being tortured at times. The way the nerves were hitting. But once it was cancer, everything shifted, and it was kind of like the pain isn't the important thing. It was kind of like, you know, and I was exercising again, I was doing all these things that I wasn't doing because of pain. But now I was working on training my you know, conditioning to get ready for a massive surgery, and my focus all went there. And when I thought about this a little bit, from the questions that came in around how do you know to shift from one to another, and what do you do? And actually, it comes back to DBT. You know, DBT is working with people who often have these multiple problems. And we have what we call a treatment hierarchy. You know, we organize ourselves. What's the most important thing? What's the next important thing? Which lets us, as DBT providers, move quickly from this is the target. Oh no, that's the thing. And while I never thought of it in exactly those terms, I mean, I always knew I had my priorities. Reflecting on it, this is my cancer treatment hierarchy. And actually it's very clear, and it's the disease, what am I doing? Is there something that needs to be done to try to control the disease? Is there something I can do that I'm to focus on? Is it a surgery? Is it a radiation? What am I doing?
That's your highest, that's your first priority.
That's the first priority. If there's movement there, then I can look to the next thing. The next thing that's been the focus, at least the way things have worked and the way I've done it so far, is really, am I able to think? Am I able to think? Am I able to function mentally? Which relates to things like, can I work? Can I communicate? Can I, whatever that is? And that hasn't been the focus, except for when I get involved with things that make it hard to think. And, and that comes to some of the next ones. The next one after that is my physical functioning. Times where I go back into physical therapy because something is not working. I'm right now back in physical therapy because of ways that my reconstruction is affecting my, ways that my body is compensating that's not, creating problems, to make sure I can do, my body is mobile, which it is. It's incredibly mobile considering the condition it's in. After that comes pain. And is there anything that can be done to help? I'm in chronic pain. My body hurts right now. Sometimes it hurts a lot more. Sometimes it hurts a little less. But it's challenging. And are there things to do on pain? And things to do on pain, some of those relate to skills. A lot of them actually relate to skills. Some of them are there medications, and that I do take. There are anti-seizure medications that are approved for treating certain kinds of nerve pain. I have nerve pain. I've been on some of these different anti-seizure medications. Some of these medications worked fine, and then after I was on them for a while, I started to develop cognitive symptoms, like I was getting mentally fatigued and physically fatigued, and I needed to get off because I'd rather have the pain. And that's come up numerous times. Coming off surgeries, they give you medications, and the balance of being on a medication versus I can't think the way I want to think. For me, it's very obvious. I'd rather have the pain, and there's a balance in there.
Because being able to think and think effectively is higher on your
higher on my hierarchy.
Yeah.
So that's me move, and it becomes very obvious. I'll try things, and then I'll see what happens, and then it becomes very clear. And then what I've been addressing after that really I think is the next priority. It's only recent that I'm really throwing skills at it and problem solving, is fatigue. Fatigue has become, it's been present pretty much throughout, but there's been points where it's interfered more. Some of the medication trials have brought on more fatigue that's made it harder to function in ways that I want to. Or at least they've infringed on more of what I hold on to, because I do let go of a lot, but I try to hold on to certain things. And then it becomes, is there some problem solving to be done there? Is there acceptance to be done there? Is there, what can be done there? But it's kind of this whole list of cancer related stuff. And it's kind of impossible to actively problem solve, just like in DBT that we do. You try to do 2-3 things, go after 2-3 targets at the same time, and you don't do anything. So you organize, so that's both kind of my mind, I think, and myself, but it certainly is what I've been practicing for years and years in the clinical space.
Right.
Yeah.
I mean, it sort of roughly parallels with the idea that if you have any kind of pain or disability, you could, and I've worked with a couple of kids like this that don't want to go to school because they have pain in their belly. And it's understandable they don't want to go to school, and sitting through a classroom quietly when you're in pain is terrible. But then the question is, what's your hierarchy? Because the idea would be, hopefully you want to get to the point where people can say, you know, what I most value is remaining functional. So that it's sort of like if you have an injury in sports or an injury at school, like, do you sit on the sidelines seeing the trainer and trying to get ready to go back in the game, or do you go home? And then you're not even close to the game anymore. So I think for me, that's been a metaphor that I relate to when I hear you talking. It's sort of like your higher priority things are like, can I solve this? Let me do that. Can I keep thinking straight? I value my thinking. So let me do that. And then somewhere down here, even though it sounds like the worst of the worst, is the pain, the fatigue, the limitations. But it's kind of like, how do I keep going? How do I stay in the game, even though and carry this with me, instead of have this become my total roadblock?
Right. Yeah. And you know, points where frustration has taken over, you know, where it's really been lots of frustration, were points where some of these lower things prevented me from functioning, you know. And you know, so that's you know, I remember that coming up pre-diagnosis when my pain was getting out of control, and I have vivid memories of being in supervision sessions, trying to focus on what my psychology intern was telling me, and my pain kept shooting and distracting me from being able to communicate. And it was, I remember that frustration, and that was again before we figured out like what's going on. So, but it becomes very clear, you know, and I think it becomes, while all of these things are challenging, knowing what I'm focusing on, and at times dropping one because a higher one just popped up, and you know what, you know, that's not it. And it also relates to the difference between acute pain and chronic pain. You know, acute pain, there's often a reason that you need to stop what you're doing and attend to it. But once it's pain signals that aren't really, you know, making a difference in terms of how it's going to function, how it's, you know, that there's essentially nothing to be done. And then it's a question of, can you accept it or can you do anything about it? And to, anyway, so that was one thing I wanted to share, because it was touched on and there were questions about it. And I thought kind of giving that organization might be helpful.
Let me suggest to just to you, Seth, and anyone who would care, who's listening, that I remember, I don't know how far back it is, but among the podcasts I've done, there were one or two in a row I did that are called No Dead Ends. Because I started to realize that if you think the way you're thinking now, you're a good example of this, is that in fact, in a way, there are no dead ends in life. I mean, you think death would be a dead end. It actually isn't, depending how you think about it. Cancer sounds like it could be a dead end, a bad cancer. It's not really a dead end. And even severe pain is not necessarily a dead end, but all of them are real. And so I tried to do a podcast of talking, and it was sort of hierarchical. It was hierarchized in a way, the way you're saying, like, well, okay, what can you do? If there's no dead end, what could you do first? And it's not different than some DBT schemes. But I appreciate, in your case, just hearing how you do that concretely. It makes a lot of sense. I think it's skillful.
It relates, what you're saying right now relates to another of the, for me, I think also relates to another of the questions that came in. This was John Mader's question, who's very active in the DBT community, and you mentioned last time. And he had a question about psychedelic medication or psychedelic substances that are currently being studied for some conditions, including cancer. And some of this pilot data showing perhaps that individuals with cancer who are given psychedelic substances may have some very significant response with regard to their depression related to the cancer, and thoughts about that. And it's something that I have thought about. I mean, it does show up. It actually just showed up coincidentally on one of the chondrosarcoma groups. Someone just
Oh,
brought this up and just put it, a link, you know, showing something about this. And it sounds like, oh, is this some kind of, you know, not cure of the cancer, but cure to this existential, you know, thing that can happen, you know, getting immobilized by the fact that one has a potentially lethal disorder. And what I was thinking, what for me, this comes back to mindfulness, and not only, you know, simple practice of the skills, but experiences that I relate to when I've really taken time to focus on mindfulness. And what I thought about, a title came up. I don't know if I'm working on a book or not, but a title came up of, in DBT, we talk about crisis survival skills, and thinking about mindfulness as existential crisis survival skills. You know, that there's an aspect of how do I deal with this existential crisis. Before my first metastasis was caught, I had signed up and was taking a mindfulness-based stress reduction course, MBSR, which people may not be aware was predates DBT as the first studied Eastern meditation with based treatment, mindfulness from meditation, for originally for chronic pain. And then it's been applied to all kinds of other things with all kinds of wonderful, amazing results, treating depression, treating all kinds of different conditions. And as a DBT person, and someone who has gone to some mindfulness retreats, I was aware that I wanted to get an MBSR experience and take this. And then I developed chronic pain, and then I developed cancer. And when I was in a place where things were settled down somewhat, I signed up. I had an opportunity to sign up for a course, and I did. And I was most of the way through the course when I got the scans showing, here, this looks like a metastasis. And then I finished the course. The timing worked out that I was able to finish the course and have my surgery. And I can't remember when I signed up for it, but I did go to another mindfulness retreat, the only one I've attended since I've been you know, dealing with the cancer. And it was a Marsha Linehan retreat in Tucson, Arizona. It's a 3-day silent retreat. And you get interviews with Marsha, a really amazing experience. And I was struggling with my mortality and struggling with the diagnosis and what's happening here and what does this mean for my career and what's this mean for, you know, just all kinds of things. You know, where's this going? And and toward the end of that retreat, during a walking meditation, I had this this awakening, this epiphany that was about seeing myself, and, well, not just seeing myself, seeing cycles of life and death, and how things are connected, and really things that I think connect to what you're talking about, no dead ends. That all these connections and ways that things go on, and you know, I just had this experience of being part of a much larger cycle than just my own, you know, what happens to me, you know, it's me, I've got this disease, and it became this much larger thing. And when I think about mindfulness retreats I've been on, think about that experience. Think about this question about, you know, psychedelic you know, taking psychedelic substances, and you get this, you know, some kind of a awakening. It makes me think that these are very much connected. And another thing I mentioned is hearing about astronauts who are out in orbit and they get to see the Earth, and they talk about when they first see the Earth, when they spend time looking at the Earth, suddenly the problems of the Earth seem completely different. Their whole mindset shifts. And I think that the psychedelics are potentially a shortcut to getting that awakening. I suspect that the people that sign up for the research might be likely to be more open to the possibility of getting that benefit. My personal recommendation would be to seek some of these other ways of getting that. You know, I would encourage people to try mindfulness and maybe MBSR, to try different practices in that direction, to try to deal with the existential crisis, rather than rush to a pill, you know, rush to a substance. But who knows? Who knows? Maybe that could be applied broadly to people, with much more positive than negative effect. You know, but I'm not jumping on the bandwagon. Oh, I had this epiphany. I think others should get it much more quickly.
Yeah. By the way, having had that kind of epiphany, has that in some way stayed with you? Does that continue to affect your thinking or your functioning about dealing with mortality and cancer?
Yeah. You know, something that you know, this duality of having a cancer and not knowing what my prognosis is. You know, I have in mind what I'm going for and what I'm trying to do, and I really don't know what's going to work and what's not going to work, and the odds aren't great. You know, I try to improve my odds and do things to improve my odds, but it also makes this duality of what kinds of projects do I get involved with? What kinds of commitments do I make? What's work that I do that depends on what I do directly, versus what do I do that's contributing to others? What do I do that's joint projects? What are things that are not dependent on me? And much more of the time, I'm leaning in those directions. I do have things that are dependent on me, generally at this point because of challenges with finding the people to share the projects with. And even then, it's much more about building up other things than about, you know, my personal ambitions. You know, so my focus on my own career, my own life has shifted a lot. And I think that some of that epiphany has made this a much more comfortable, you know, openness.
You know, I'm curious about this, and we don't have time to go in it more, but I think next time we talk in a week from now, if there's something we didn't get to that I hope we can at the very beginning, and then bring Rebecca in to talk about her experiences. But you and I had talked a little about, and it sort of borders on this, is, I don't know, once you're in these situations and these are the cards you've been dealt, how do you deal them without resentment, without bitterness? I was running a group last night, and somebody was talking about something she's coped with, and I said, and how are you left with that? And she said, I'm just bitter all the time. And I don't think that's unusual. I think it's letting go of things again and again. So I wonder if next time we could just touch, at least at the beginning, a little about letting go, living with willingness within a situation that you would never have chosen in a million years. But now you have to find how to live within it and how to make the best of it, and how to hopefully spend as little of your life as possible just being bitter in a way that doesn't actually go anywhere. So I'd love to hear a little about that. It sort of follows a little bit one step away from what you're talking about now, but I'm just looking at the time, and I know we have about 1 minute.
It sounds like a good plan.
It does. Okay.
Yeah.
All right. Well, look, again, I don't want to make some sort of I can't make any kind of capstone comment about what you're doing. It just speaks for itself. And it's very, I'm just so interested. I think your story and your way of holding your story and your way of experiencing it and living with it and coping with it is just remarkable. And I have no doubt people will learn from it if they sit and listen to this. So
I hope so.
Well, that'll go on. So I'll see you and your wife next week. Well, we'll continue this conversation.
Thanks,
so,
Charlie. And
thank you very much.
And thank you, everybody.
Yeah. Yeah, bye everybody. Take care. Bye-bye.